All right. Like to call the House Health Committee to order. Will the clerk please take the roll? All right. Madam Clerk?
Mr. Chairman, you have 24 members present. You have a quorum.
All right. Thank you. And before we get going with the calendar, do any of the members have any personal orders? All right. Chairman Martin, you're recognized.
Thank you, Mr. Chairman. I see one of my doctors out in the audience today, Dr. Patrick Andre from Milan, Tennessee. Greatly appreciate him being here for TMA Day on the Hill.
And thank you, not to forget all the other doctors that are out there with TMA down the hill. Thank you guys and all the white coats that are out here as well. So we're gonna get to the calendar, and we have 12 items on the today's agenda. And let's see, before we get to the agenda, item number 2, House Bill 2020 has been rolled 1 week. And so without objection, we're going to go to item number 7, 1665 has been rolled 1 week. And so without objection, we're going to go to item number 4, House Bill 1819. Or excuse me, 819. Now you have a motion and a second. You're recognized.
Thank you, Mr. Chairman. Members, this is the certificate of need bill that we passed last session and received it here in the full committee. And I do have an amendment that we need to adopt to change an effective date. That amendment code, Mr. Chairman, is 14451.
Okay, I need a motion. A second. Okay, if there's no objection, all in favor of adopting amendment 014451, say aye. Aye. Opposed? Ayes have it. We are back on the bill as amended. You're recognized.
Thank you, Mr. Chairman. Now that this amendment is in the correct posture, this takes out acute care from the certificate of need statute with an effective date of July 1, 2030. However, I believe there is another friendly amendment that I would like for the committee to take up at this time, Mr. Chairman.
Okay, we have an untimely filed amendment, I believe drafting code 014596. If there is no objection, we will hear that. Okay, I need a motion. Motion and a second. Mr. Speaker, you're recognized.
There we go. All right. Thank you, Mr. Chairman. Yes, so this amendment comes to us from several different entities. But what this does, also working with the administration, this adds freestanding emergency EDs as well as cardiac cath to the removal of the CON for within 2027. Also, what it does is the reason this amendment was untimely filed, which I appreciate y'all voting to hear it, is what we have done in the past with other things on CON when they come out, we put them under licensure. And so there was one amendment, if you look in your pack, that was need to be redrafted. So what this will do is move freestanding EDs as well as cardiac cath in 2027. It also sets up a licensure process, much like we did for open heart surgery and NICU and burn units. It stays under licensure. And then we also wanted to make sure that we don't follow the Texas model, which is where you have private equity companies coming in and putting all these things up. And so this makes sure that these two things that are rolling off would also be hospital-based as well, which protects us, which means they have to be hospital-owned entities. And so that's what this amendment does. Be happy to take questions.
Do we have any, Chairman Williams, you're recognized.
Thank you, Chairman. Thank you, Mr. Speaker. The previous amendment that was adopted dealt with acute care and the dates. This amendment, Mr. Speaker, just to make sure I understand about the implementation, because we had 2 years ago, we had a phased out to licensure. The two entities you're talking about, you're simply adding them to the next phase of licensure. But does your amendment change the acute care amendment that was just put on previously?
You recognize?
Thank you. It does not change anything to do with acute care. That's still based on that amendment comes out at 2030, some date in 2030. What this does is freestanding EDs as well as cardiac cath. They come out July 1st of 2027 with a component to have licensure and hospital based as well.
You recognize?
Thank you. The other question that I had is, I don't know, you probably know more than this than I do, so I'll ask you. The radius requirements for FSEDs, even in the amended form of licensure, does it stay the same, or is that going to?
You recognize?
That is defined by the federal government, and so that radius is defined by federal statute. My understanding is, I believe it's 35 miles is what the federal government defines. That stays intact.
Thank you.
Any further questions for the speaker on the amendment? Okay, seeing none. Okay, we're ready to vote on the amendment. All those in favor say aye. Aye. Opposed? Ayes have it. We are back on the bill as amended. Representative Garrett, you recognize.
Thank you, Mr. Chairman. As this committee and this body has been dealing with the certificate of need area, I do believe that this is going to provoke more competition, better health care, so we can serve our constituents across Tennessee to make sure we deliver the best health care that we possibly can. So I believe that with the amendment that you just adopted, along with my amendment of the acute care, I think this bill is ready in the posture for your support. So I renew my motion, Mr. Chairman.
All right, Chairman Williams, you're recognized. And then we will go out of session at some point in time. We have some folks that want to testify and come back. Okay, Representative Hemmer, unless you want to do this out of session, or is your question to him? Okay. All right. Seeing no questions at this time, we will go out of session. And I believe we have, if all three could come up, we have like a Lacey Blair, Scott Tongate, and Tina Prescott. And if y'all each have 3 minutes, and I'll give you the countdown here, but if whoever wants to start first, each has 3 minutes, and then we'll take some questions.
Is it on? Oh,
Okay.
There we go. Sorry.
All right, you're recognized.
Thank you, Mr. Chairman, and thank you, committee. Lacey Blair, Tennessee Hospital Association. I want to thank you for the opportunity to speak on House Bill 819. THA has worked collaboratively with the General Assembly on thoughtful phase CON approach reform and approaches over a number of years, starting in 2016, again in 2021, and more significantly in 2024. Hospitals have not resisted reform. Instead, we have tried to partner with you all on it with the goal of balancing access stability, particularly where rural hospitals are concerned. With respect to House Bill 819, THA is neutral on the amendment that removes acute care from the CON requirements in 2030 and moves it to a licensure process. The neutrality is a reflection of THA's executive committee. However, I want to be clear that hospitals across the state are not uniform in that position and may continue to have serious concerns about repeal in 2030. As for the other amendment and the language that deals with FSEDs and cardiac cath, THA is strongly opposed to those provisions. We feel that moves beyond the current discussion of acute care repeal in 2030 and introduces potential and additional structural changes that deserve separate review and deliberate consideration. They shift financial and service line risk onto existing hospitals that provide 24/7 emergent care, trauma coverage, and services regardless of payer mix, especially in those rural communities. This is not theoretical. It affects local employers, workforce stability, capital investments, and more importantly, patient access to care in the districts. To speak directly to the rural impact, I'd like to introduce Tina Prescott, who is the president and CEO of West Tennessee Health, and Scott Tungate, who is the CEO of Macon Community Hospital, one of Tennessee's only remaining independent rural hospitals.
All right, Ms. Prescott. Okay, you have 3 minutes.
Right.
You're recognized.
Good afternoon. Thank you for allowing us today. West Tennessee Healthcare is a regional safety net healthcare system that's serving the entire region of West Tennessee outside of Memphis and Shelby County. So that's about 600,000 lives that we serve from border to border and river to river. They're outside of Shelby County. This is a health system that's been operational for 75 years and operating without any local tax support from the city, from Jackson and Madison County. In a healthcare system like West Tennessee Healthcare that is providing safety net services for a very rural area, removing the certificate of need isn't about competition. It's about the potential collapse of an internal subsidy model where your higher margin profitable services like elective outpatient surgery or advanced imaging subsidize the services that generate that are unprofitable but essential, things like obstetrics, emergency care, behavioral health care, mental health. When new private entrants cherry pick those profitable services, the funds that keep that safety net provider rolling and going in a financially sustainable model, they disappear and access to care is put at risk. An example of that is a new micro hospital opening in Jackson. That new hospital provides limited services that are just financially sustainable and transfers that medically complex costly patient to West Tennessee Healthcare. We're left with the highest concentration of the complex care while caring for the highest ratio of TennCare and uninsured patients. And that math just no longer works. Stripping away CON protections leaves us unable to operate a safety net provider, a safety net system for these rural areas without additional funding. The same fate that faces other public hospitals in other parts of the state. And these rural communities in West Tennessee would bear that cost. It's one of those things where this fragile healthcare ecosystem, particularly in these rural areas, is adding, we need that to demonstrate community need, not just market opportunity in these areas. So one of these things that CON helps ensure that rural patients maintain local access to comprehensive coordinated care close to home. The communities of Bolivar, Camden, Dyersburg, Milan, Martin, and Paris depend on West Tennessee Healthcare for services that no private competitor will provide. Losing these services doesn't just affect our patients, it threatens the economic stability of that West Tennessee region.
Thank you. That was perfect timing. And so, Mr. Tongate, you are recognized.
Good afternoon. My name is Scott Tungate. I've been in healthcare for 35 years. I've been in rural healthcare for 35 years. I have worked in Clay County, Jackson County, Macon, Smith, Trousdale, and Lauderdale County in Tennessee at different hospitals throughout my career. I've seen what losing a small rural hospital does to the community, and I believe some of the amendments to this bill would potentially devastate small rural hospitals. Tina, I know, has at least two critical access hospitals, and I'd just like to talk about the impact of critical access hospitals if this bill goes through as is. Right now, critical access hospitals have to demonstrate a 35-mile radius where no new hospitals are built. If a new hospital is built within that 35-mile radius, that critical access hospital could lose its designation, probably would lose its designation, as a hospital in California this past year lost its designation for losing that 35-mile radius. It closed within 2 months. If a critical access hospital in Tennessee loses its designation, it will close within a year. That's not hyperbole, that is facts. We only are break even. Macon Community Hospital has lost money 3 of the past 5 years. That's a fact. If we lose that critical access designation, we will lose money every year and not be sustainable. I've seen the impact of losing a hospital in a rural community in Jackson County. While not a large county, 20 years ago, it had double the residents in the community. When the hospital left, the industry left, the people who made money, supported the tax base of the community left, and all that were left in the community were the poor and the elderly who could not leave. That is not what I want for Macon County. That is not what I want for rural Tennessee. And I thank you for your time.
Thank you for those comments. And while we are out of session, I think there were some folks that had originally had some comments. Do we have any questions? Speaker Sexton?
There we go. Thank you, Mr. Chairman. Hey, there was a term used that I'm trying to figure out, but you referenced West Tennessee Healthcare as a safety net system. I know we have one safety net hospital, which is Nashville, and then we have a lot of behavioral health systems that are safety net. So are you saying that, I mean, we can ask legal, they're trying to find it, but there's safety net hospital systems defined by state code?
You're recognized.
I'm sorry. Jackson Madison County General Hospital District is a private act hospital formed in 1949. And as part of that, part of our private act is to provide for the indigent needs of that community as a healthcare, both from a medical and behavioral health standpoint.
Correct, but every hospital does that. So every hospital technically under your definition would be a safety net hospital then?
No.
Because they care for indigent people.
We are a governmental, not-for-profit district hospital that is designated as a safety net hospital.
By your private act, not by state law.
We can check that.
I mean, it's just point of clarification, because I think we need to be very clear. If we say we're a safety net hospital, my understanding is there's one, which is Nashville, and then we have some safety net healthcare centers as behavioral health systems. And I don't want to throw around safety net, which is or is not in system based on a code. I think that's something to talk about. And because a private act doesn't make you a safety net, state code makes you safety net. That's the way I look at it. But, and then also, when you remove acute care from CON, you still have to be accredited, correct, as a hospital? Accreditation?
You're recognized.
Yes, we have to be accredited.
And you're accredited via who?
You're recognized.
West Tennessee Healthcare has typically been accredited. Instead of using the Medicare certification process, we have always used the Joint Commission as our accrediting body.
Right. And so even though you remove CON, you can't just pop up a hospital and anywhere in Tennessee without being accredited by a Joint Commission or somebody. So there's an accreditation process offering certain services that define if you're a general hospital through accreditation or a specialty hospital. So just removing CON does not mean that you're not going to have the parameters of being an accredited hospital or you're not providing the services potentially, because you have to be accredited.
You're recognized.
Was that a question? I didn't hear the question.
I can't open up a hospital and not be accredited.
You're recognized.
You can build a hospital if, with your amendment in your bill, you could build a hospital through licensure. You're not Medicare certified until you open the doors and see your first patient.
You're recognized.
Correct. But in order to be reimbursed, I still have to be accredited by Joint Commission or somebody.
No, that's not correct. You have to be certified by CMS.
But there's an accreditation process to be a general hospital that defines what services you have or don't have. You have to be accredited. You have to have some sort of accreditation.
No, sir, you have to have Medicare, CMS certification is
Is-
all that's required.
Correct.
In
but
other
that's-
states, I've worked at hospitals that did not have accreditation. They had CMS certification.
Okay, certification, accreditation, you're still certified by CMS to see patients.
That's correct.
You can't just open your door and start seeing patients.
That's correct.
Okay, so there is a level of comfort there to protect you. And then also on the freestanding ED and the cardiac cath lab, does the amendment not say that you have to be hospital owned to offer those services?
You're recognized.
Speaker, I mean, with it late timely filed, I'm going off of what was stated in the committee, but you did state that, yes, those two would have to be associated with the hospital.
Right, just for clarification, Section 9, Section E, or to be licensed pursuant to this section, a satellite emergency department or cardiac cath must be affiliated with the hospital. Must be affiliated with the hospital. So I'm trying to figure out in West Tennessee, unless I come in and build a hospital, how can I provide a freestanding ED without building a hospital?
You're recognized.
So my understanding, if is correct, so of the way that the language that you're describing, it sounds as if you would have to be affiliated with a hospital. I do know there is a process through CMS where you can ask for a waiver for that 35-mile rule, but without seeing the language in front of me, it sounds like you are being more explicit that it has to be tied to a hospital.
Yes, it has to be affiliated with hospitals. So my question, so removing freestanding EDs does not mean, again, that anybody can open up a freestanding ED in any part of our state. If you're West Tennessee Healthcare or if you're another and you have a hospital, you can do that and you're protected from that realm. So before somebody in West Tennessee can do a freestanding ED, they have to be affiliated with the hospital, be hospital-based, which means that there is some protection there of what is allowed and what's not allowed. And I'll stop there. Thank you.
All right. Other, Chairman Clemens, you're recognized.
Thank you, Mr. Chairman. We're constantly concerned about the availability of accessible healthcare in rural areas across the state of Tennessee, especially. Please elaborate for me. I think you said this is going to result in the closure of small rural hospitals. Can you explain how and why that is and any threat that poses?
Sure. The way it's written, Sumner Regional Medical Center and Hendersonville Hospital or Medical Center could open up a freestanding ED right in the middle of Lafayette, siphon off probably half of our admissions to Hendersonville or Gallatin. That would cut our inpatient volume in half, and we would lose the ability to be sustainable.
You're recognized.
Thank you, Mr. Chairman. And to your knowledge, are there any other such hospitals across the state of Tennessee in rural areas where this is also going to be a similar situation potentially?
You're recognized.
Yes, I know Carthage, Hartsville, Woodbury. I mean, if you go from Nashville East, just about every small rural hospital could be impacted by that. When you get closer to Savannah, Tennessee, when you get down toward Lawrenceburg, when you get, like I said, east of Nashville, several small rural hospitals could be impacted by this.
Thank you, Mr. Chairman.
All right, thank you. Chairman Williams, you're recognized.
Thank you. Thank you, Chairman. Mr. Tungate, you mentioned briefly a minute ago about Jackson and its closure there. I'm familiar with this hospital, particularly since it did close based upon the parameters which you just described and its impact to the local community. I do think it's interesting as it relates to the discussion for the purposes of this discussion. Cookeville Regional Medical Center bought that hospital several years ago in an effort to try to improve the overall healthcare of it. And even though Cookeville Regional Medical Center was a larger hospital than Jackson, why would you say that didn't work? Was it because the people had already left?
Yes, most of the people had
You recognize.
most of the people had already left by the time Cookeville had acquired it, and the pattern of delivery of care was going toward Cookeville anyway at that point.
Right. And so really the only remaining asset that's of any value for that hospital in Jackson County is really its CMS designation, in that if that's really what Cookeville Regional Medical Center bought, and that's really what the current owner bought, was the access to that CMS data. Is that not correct?
You recognized.
The CMS designation?
Yes, sir.
Yes.
Thank you.
All right. Any further questions while we are out of session? All right. Seeing none, thank you for your testimony. We will go back into session. And Representative Garrett, you are recognized.
Thank you, Mr. Chairman. A couple of notes as I was listening to the testimony of the panel, and I hear their concerns. 75 years is a long time for doing things the same way, right? I heard when some of the cities were listed off in the West Tennessee area that the sentence was said, no private entities will provide. And the problem is because they can't, because of the certificate of need process. And I believe that's the reason why this needs to be out of the CON process, to make sure that these communities can receive the best care that they possibly can, and not be slowed down by the cost of a archaic, in my belief, certificate of need process. So with that, Mr. Chairman, I'd be glad to take any questions.
Okay. Do we have questions for the sponsor of the bill? Representative Henry, you're recognized.
Thank you, Mr. Chairman. Thank you, sponsor. I was just curious from an overall standpoint. I know we've had a lot of discussions about the rural health transformation program and having some administration amendments or administration bills around CON reform, and was curious how this bill fits in with the broader strategy. And I think there's supposed to be some more bills potentially around CON lines of service. So I'm just trying to wrap my head around that. If you describe, please.
You recognize.
Thank you, Mr. Chairman. I think this is consistent with what that would call for. There could be more things that are happening. There's obviously another piece of legislation that's out there. I'm not sure what that's going to happen, but this is the posture of where this bill would be, with the three things that we're eliminating from CON that I think would be consistent with taking full advantage of that opportunity that you mentioned.
You recognize.
Is there a reason why they're piecemealing it and we're not having one cohesive item so we know what all lines of service are going to be CON?
You recognize.
I don't have an answer to that process other than what you have before me in this piece of legislation that takes care of the three items that we're discussing today.
Good. Chairman Williams.
Thank you. All the discussion, I'm a little bit confused. I'm hoping you can help me. So the FSED and the cath lab, they're moving to licensure. And instead of the year that they were going, they were previously excluded from the CON reform that we did 2 years ago, but we're adding those two to the next cycle of move to licensure. Is that correct?
You recognize.
That's my understanding.
Okay. So I wondered if you could help me, because I'm a little bit confused. Who determines what the definition of acute care hospital is?
You recognize.
Well, I don't know if that's in the statute or not. I mean, my understanding of acute care is immediate care for emergency purposes of someone that needs something now, not prolonged, not chronic, et cetera. I don't know if there's a definition of acute care that's in the actual concept, but the industry has that definition and knows what acute care is that's going to be specifically removed from the CON process.
You're recognized.
Sorry, Chairman. So the reason why I asked that question is, there's a little bit of discussion. I've asked a few of the large hospitals in the room and a few of the small hospitals in the room and said, what is acute care anyways? Is it clearly defined? My understanding is it's not clearly defined in the statute. Maybe it's a question for legal. And if it's not clearly described in the statute, then should we not at least describe what that is if we're going to release whatever it is?
Chairman, if we can go out of session here, I think a legal might be able to answer your question. Or without objection, we're going out of session. Legal Services, Heather, you are recognized.
Heather Asbell, Legal Services. Chairman Williams' question was the definition of acute care hospital. That is defined in House Bill 819 as means a hospital with the primary focus of patients with an average length of stay of 25 days or less.
Cool. We're still out of session, so you're recognized.
Okay. So do we classify like are the hospitals that are currently licensed in the state or under CON or however they're done through the health facilities group, do we determine what that licensee is at the time of licensure? Like, do we, for instance, like Cookeville Regional Medical Center, does their operational, and maybe in their private act, but if are they designated as an acute care hospital? Is any other hospital, is Vanderbilt, I see him in the room, is Vanderbilt somehow defined as, or that definition applied to them?
You're recognized.
My understanding is, so for this bill's context, Representative Garrett defines acute care hospital. Now, if it's the will of the committee to pass and then the will of the General Assembly to pass this legislation, then that definition would be in the public chapter 985 that was passed in 2024, and thus be in statute. But currently it is not defined. So I would have to get more information about how hospitals determine what acute care hospital is currently. It's just not defined currently. And so Representative Garrett is defining it in his bill. And if it's done by private act, that would be specified in the private act, my understanding.
Chairman Williams.
Okay. I think that's it for legal.
All right. Without objection, we are going back in session. Representative Garrett, you're good?
Yep.
Chairman Williams.
Sorry, I was trying to go back to it. Based upon the testimony that they have described here today, these two hospitals really remind me a lot of the hospital in which the district in which I reside. This hospital is a private act hospital. This hospital, by nature of this body years ago, adopting it as a private act safety net hospital is kind of a misnomer in that the speaker is right. They're not dubbed a safety net hospital because the state determines that, but in their private act, because of what they do and the services they provide in healthcare, it does in fact do that. As it relates to the CON being removed from that, my concern about, and I appreciate the FSCD portion of your bill. I appreciate you and the speaker's work on it and the cath lab. I think nothing wrong with that to me. But my fear is one of your amendments today had to deal with COPA. As somebody who grew up in Upper East Tennessee, I was born in a hospital there called Holston Valley Hospital. And that hospital was the premier hospital at the time. 10 years ago, this body passed this COPA antitrust protection bill, of which I hoped your bill, as I told you, I hoped your bill the caption would carry it, because what happened as a byproduct of that legislation that we passed, I voted for, the overall quality of healthcare and the competitive nature of said healthcare has gone. It's completely decimated. The whole area is just ran by one group who has anti-protection lawsuit. My concern about removing CON instead of moving everything to licensure has always been about payer mix. When you said, hey, let's move this bill out last year to full committee and we'll park it there, that was my concern then. Just like it was voiced here today, my fear is that if we remove CON, that when we do remove CON, the counties of Putnam, Jackson, White, Overton, Fentress will all be among implementation within months of 2030, and when the new hospital is built, and it will, that Cookeville Regional Medical Center that has provided services for the last 50 years in the Upper Cumberland will be gone. It will be gone. Those people who are in the 6th District, who are very passionate about their healthcare system to the point where they didn't want to sell in 2000, it really concerns me that particularly when we're focused so much this year on rural health transformation. This is transformational. I really feel like it's going to be transformational in the wrong way, unfortunately. And I appreciate your tenor. I think you genuinely believe that that's not the case. I do. But as someone who served that community for the last 20 years in public office and who served that hospital, I'm extremely concerned about the repercussions of removing CON for acute care hospitals to those rural folks. Because quite frankly, the rural transformation money, of which they probably won't get much, won't do very much for these hospitals once the vultures are able to land. So I appreciate your work on this. I know you're very passionate about it. And I do think it's going to be a difficult road to hoe for rural communities, as they said, in Sumner, West Tennessee, Murray, Cookeville Regional Medical Center, and many others, the last 6 rural hospitals that still exist in the state. Thank you.
Okay. Thank you, Chairman.
Thank you for your comments.
Speaker Sexton, you're recognized.
Thank you. Just a couple of quick points. One, if the definition of a safety net hospital is indigent care, HCA, Vanderbilt, LifePoint, St. Thomas, Covenant, they're all safety net hospitals because I believe they all do indigent care. So you have to be very careful what you describe and don't describe yourself. Also, Representative, in rural communities, if you're in business in a new hospital, I'm going to say it's going to cost you $400 million to build a new hospital. And I think that's probably low, but somebody can out there point their finger up if it's higher than that. Are you going to spend $400 million going into a rural community to compete with a hospital where there's not enough market share there? Does it not become a business decision and you're looking at the parameters, much like Montgomery County this last year, which has had 2 hospitals with 260,000 people. They needed a 3rd hospital. It took years to get a 3rd hospital because they had to go through CON. The market conditions called for it a lot earlier than they got it. So is there not an aspect here in healthcare when you remove the CON on the hospital side that the marketplace and the business model and the cost with what's happening locally drives that decision instead of the state arbitrarily deciding what should or should not happen?
Yes, I agree wholeheartedly with that free market analysis. When it comes to a hospital coming into a small community, it doesn't make sense to put a $500,000 asset there when it may not be sustainable itself, much less the other hospital or whatever facility you're talking about could be competitor with that particular. So it doesn't make sense. I think the market will drive that, and the market will drive different. There's not, I believe, there's some hospitals being built, but they're not being built like they used to 50 years ago. Healthcare is changing. People are staying in the hospital less. They need different needs than maybe a traditional hospital could actually provide. And that's where I think the marketplace should drive those decisions. And that's why I believe certificate of need hinders those decisions to be made.
I hope where I live in Crossville that we get to a point where we can have a functioning second hospital, because that means we're growing, we're a thriving community, and it gives us more access. The other thing is on payer mix. I've heard the payer mix rationale. Is it not true that hospitals have to see anybody who walks into their ER and give them care regardless if they have health care or not?
You're recognized.
It is, yes.
So they're all going to see indigent care. They're all going to see various types of individuals with payer mix. I will say when we rolled back CON on imaging, there was a lot of conversations about cherry picking and payer mix, and that hasn't come to light as well over the years. And then another question, do you know what percentage of people who go to a freestanding ED actually get admitted to the hospital through the freestanding?
I would imagine it's low, but
It's only 10% of the people who are seen in the freestanding EDs actually get admitted to the hospitals. And it's more designed, the freestanding EDs in my mind is more designed to protect the emergency rooms in the hospitals, to see the people who are there for those life-saving emergencies or other emergencies. And the freestanding offers you the capability of getting some access or care that may be best not suited to go to the hospital. And I think that's one reason why it's low, and it's a different, interesting mix. The last thing I'll say is there is an attempt, I think some to want to define what acute care hospitals are or what hospitals are. They're defined by the accreditation process through Joint Commission. They're defined by CMS through the accreditation process. And there is no federal, basically acute care type of hospital. It's general hospital, it's other hospital. If we start in statute defining outside of licensure, let licensure handle that. If we start defining in statute what a hospital is, all you're doing is then putting CON into statute. And you're taking away the capability to have the flexibility through licensure to make that determination. So you're just replacing one CON for another type of CON if you start defining it to a certain degree.
All right, Chairman White.
Thank you. If I could ask a clarifying question, and if I've misunderstood, correct me. We said that this freestanding ED would have to partner with the current hospital, or whether it be the rural hospital or what. Is that correct?
You recognize?
that's right. That'd be affiliated on by code with the current hospital in order to erect an ED within 35 miles of that hospital. I'd be part of that hospital system or
Right.
affiliated with that hospital.
So it seems to me, and correct me where I may be wrong, it seems like if you had outside capital in a freestanding ED partnering with the rural hospital or whatever hospital we're talking about, it brings capital into that hospital, which is already maybe, has more expenses than income. Why wouldn't it benefit the existing hospital?
You recognize?
I think it can. That's the purpose of that particular provision that protects that 35-mile radius for a freestanding ER, because they're the only ones that can do it under this statute.
You recognize?
Thank you. And to the point then, what we mentioned, like it takes, like in Memphis, we need one new hospital. They want one. It's $400 or $500 million. But if you could bring, and that's tough. So if you could bring new capital into, especially a rural area, to support that hospital, it seems like that makes sense to me, unless I'm just off track.
You recognize?
Thank you, Mr. Chairman. You kind of nailed that. One of the reasons why I support this concept is because to build a freestanding ER would use a whole lot less capital than building an entire hospital, right? And now we're prevented to do that. Like was said, that there's no private people that will do it in the West Tennessee areas because they can't under the CON regulations. And this particular bill, they would be allowed to spend that capital to better serve its community and not spend the capital it would cost to build an entire hospital in this regard. So.
You good? All right, Chairman Clemens.
Thank you, Mr. Chairman. So we're hearing conflicting testimony. I mean, the sponsor and representatives of THA and these healthcare associations, and I'm hearing this argument that we need more competition. The market's going to take care of itself with increased competition this is going to allow. But on the one hand, if a big hospital chain or somebody comes into rural areas and it does what they're explaining, it's going to shut down that rural community hospital, then you're eliminating competition. And so then they're going to have a monopoly. So how rationalize for me, if we're eliminating rural hospitals and allowing new big ones to come in, and if what they're saying is accurate about those rural hospitals shutting down, now you've only got one player in town again. And how are we going to control the prices and the whatever is provided there for the benefit of the patients? I mean, that's what this is all about, right? I mean, if we're not here for the patients, then what are we doing? So if we're only going to replace one hospital with another one, I guess I'm having trouble rationalizing how the market's going to take care of the situation that is, to the extent it's facilitated by this bill. Can you rationalize that or explain that?
You recognize?
Thank you, Mr. Chairman. I think that it's been alluded to a little bit in some members' questions that if you are in a rural setting and you have a facility that's been there for 20 or 30 years as an actual 40-bed hospital, I don't believe the market's going to support there another 40 to 50 bed or 60 or 80 bed hospital in the same community. So I don't think you're replacing apples with orange, or you're replacing apples with apples. I think you are going to enrich the market, so to speak, with different types of services that right now certificate of need doesn't allow because of the restrictions that it allows for a freestanding ER to go into a rural community and maybe service those that don't have a serious ER issue that would turn into being admitted to the hospital, right? They have got to go to the hospital. It's the only place, the only choice that they have for their health care. I don't believe this is designed to say in a small city, rural city, that they're going to build another $400 million hospital. The market's not going to bear that. That's not what the purpose, I believe, of what this is. But I do believe that the market needs to drive that. And right now, we're driving that as an entity under CON. The hope is eventually to make that competition better, to make healthcare better. But it's hard to, when you're against a particular piece of legislation, you want to speculate as to what could be the worst thing, right? I can't sit here and tell you with an honest, straight face that there might be some closures down the road. What might happen, though, is that they could close anyway, no matter anything that happens with our healthcare system, right? Hospitals close not because of certain things that we do or certain things that we don't do. It's just when you get reimbursed by the government, that doesn't go to roofs, that doesn't go to paving, that doesn't go to things that cost capital, that they can't make it work anyway, regardless of how many people are on TennCare, regardless of how many people are on Medicare, right? The market needs to drive those decisions. And that's what I think this will do by eliminating a step where they have to go ask, where their competitor has to go ask permission to compete. I don't know another industry that does that. Lawyers, dentists, orthodontists, any community that you operate in, I don't know a single sector where you have to go ask permission from your competitor to compete with them. I don't know another industry that's like that. And we need to come away from that to see if we can do better. Now, I can't stand up here and give you 100% guarantees, but I can tell you, as Representative Williams said, that I believe in this. I believe in the market. I believe that we can deliver better health care for all Tennesseans. And I think to start with is to get the government out of the way.
You recognize?
Well, I think we get the insurance companies out of the way too, but that's beside the point. Answer me this question. So let's say you saying if there's a 40, 50 bed hospital, the market wouldn't support another one in that market, right? And they would come in and provide other services theoretically. But what if you've got an 800-pound gorilla that wants to come into the community? They're like, okay, well, they've got a 50 bed hospital, but we're going to build one too, and plus all this other stuff. Is there anything in this bill that prevents them from doing that?
You recognize?
Does that make sense?
I think I'm following you, is that you're saying they would defy market conditions where their financial people that's advising them to build a hospital that says this market can't sustain it. Just like Nashville has hotels like crazy. I mean, if there's going to be a company that says whether or not a hotel can be here or not to sustain your occupancy rate, your price point rate, they're going to tell you, no, a hotel doesn't make sense here. So in your scenario, you'd be going against what the market would provide for that community to build a facility like that. And I don't think you're going to have folks that are going to come into the community when it doesn't make economic or financial sense. That's the idea of the marketplace deciding what should be there and what shouldn't be there, other than a government entity deciding what's in the best interest of those communities. The market should, their folks should, their community should, their leaders should, not a commission down here in Nashville. That's why I'm passionate about making sure the communities can determine what's best for their communities.
You recognize?
Well, I mean, I think in some circumstances, your investor is going to dictate what you do. And if they decide they want to throw money into something, I mean, I can point you to a bunch of empty apartment complexes around here and empty hotels in downtown Nashville that were built just because that's what the investors decided to do. So if you got that or your board wants to do it, then by God, they're going to do it. I mean, and if they think they got a better product and they've got better leverage with an insurance company and they're getting better reimbursement rates, then they'll do it. And they'll just wait out that smaller competitor being the rural hospital. And they'll just take all that business, and therein lies the problem. That's what I'm trying to see, if if there are any protections for that. I agree with the spirit of the bill. I don't mind eliminating regulation to some extent, and making sure we've got some competition or whatever. So I'm not arguing against the bill. I'm just curious if there are any protections to protect against those scenarios to facilitate that market, because the last thing we want is to try to create competition, ultimately eliminate competition, and now you got 800-pound gorillas sitting there controlling that entire market, defeating the purpose.
You recognize?
Thank you, Mr. Chairman. I mean, I understand that, but the fact is we don't have competition in this space right now. You don't have a market analysis because people are there. They know they can be there. They got to go through the CON process. It's unlikely it's going to be approved, et cetera. Here you have a different dynamic, right? You have a different way of approaching what needs to be there. And I think that, the free market, free enterprise has to determine whether or not that's going to be a valuable community to invest in. And only bring up hotels because there's a company that's actually headquartered in my district that does hotel analysis, right? Occupancy rates. No one can build a hotel without knowing that data of what that's going to look like in a certain community. That's kind of the same thing. That's the market dictating what needs to be there. And that's why I think this is so important for our healthcare space. As you well know, is so regulated and so determined by what the government does. The less of that, I believe, is better.
You good? Chairman Hill?
Thank you, Mr. Chairman. And I just wanted to quickly express my support for the legislation as a rural legislator. I appreciate the concern of this body for my district and for the rural parts of the state. And I'm reminded that I've been on a repeal of the CON process since 2013 with, it was then Cameron Representative Sexton's bill. And so I appreciate the speaker's leadership on this issue and his consistent approach. And I appreciate Representative, your leadership to bring this bill. The bottom line is that the CON process is a barrier to the free market. Many in this body have campaigned on being less government, limited government conservatives. But when we come into the healthcare space, we say, well, the free market principles don't apply. Well, that's not true. The reality is if we want to talk about affordability and we want to talk about actual patient care, we have to introduce competition into the market space. We have to. Now, where I'm from, there was a provider that spent not $10,000 to go through the CON process, but hundreds of thousands of dollars to go through the CON process to be approved. Who paid for that? Eventually, the patients pay for that. Eventually, you and I pay for that. Eventually, our people pay for that. This process has been a problem. It has been a problem in the healthcare space for too long. And so I'm grateful to see a piece of legislation that further chips away at it. And an amendment that we added a few moments ago that chips away at it further because it's what our people need and it's what our healthcare system needs to be able to meet the market and meet the moment and take care of people in an affordable fashion. We cannot government our way into affordability. It is not possible. We're not that good. The market has to take hold. And so with that, Mr. Leader, I'm in full support of your legislation.
Thank you for those comments.
All right, Chairman Kumar?
Thank you, Mr. Speaker. Having practiced in a small community and a small hospital over the years, I've seen many unnecessary battles where we were licensed for 110 beds, which used about maybe 60, 70, or 80 of those at the best of times. And patient needs were limited, needs were not full completely by us. They were because we provided limited services. So patients were frequently transferred out, and during that transfer process, it was difficult for families, and sometimes transfers were rather late, and that was not good for the patients. In that scenario, there are two things that can happen. The hospital, somebody else wants to come out and buy it. We always resisted that because my friends were on the hospital board. Part of the time I was on the hospital board. Or a new hospital comes in, and we again resisted that because we had pride in our community hospital, and we wanted it to continue with what they were doing, although the services were not complete. But the bigger hospitals that wanted to come in, either buy or build a place, they had done their market research. They were comfortable that they can spend this money and provide better services as well as financially thrive. When that happens, we can lament that the local community hospital closed, but we can also celebrate that we have better service and better services, and patients were taken better care of. Over the years, we have whittled at the CON process, taking parts and parts and parts away. And we've never had to feel after 2 years or 3 years to say that, oh, gee, that was not good. We need to go back. We've never had to step back. And I think it's time to continue on that process and complete the efforts over the years that have made so that CON process is not necessary and allow the marketplace to flourish. Thank you, Mr. Chairman.
Chairman Williams.
Thank you. Something was said earlier, and I don't know the answer. It was talked about charity care. I don't remember if it was the speaker or Chairman Clemens asking about charity care or indigent care. Does a hospital, the only place where they're required by statute, I think, is to see charity care or indigent care is in the ER, correct?
You're recognized.
I'm by no means an expert, but I believe you are correct that if they present themselves
So
to
someone
the
just
ER,
could-
they need to have services at the ER.
Right. So but it doesn't take into consideration if the ER, if they went to an ER that, or I mean, if they went to a different place and they had, and they didn't see, if they went to a different hospital and they didn't have an ER, then it could be that they didn't see any charity care at all or indigent care. Is that right?
You're recognized.
I'm Chairman Williams. I don't know the answer to that. I don't know if there's hospitals that don't have a particular ER or the ability to provide that service. So I just don't know the answer.
Okay. Thank you.
All right. Thank you. All right. Any further questions for the sponsor of the bill? All right. Seeing none. All right. I will afterwards. Will the clerk please open the board for the vote? All those in favor vote aye. All those opposed vote no. All right, will the clerk please take the vote?
Mr. Chairman, you have 23 ayes, 2 nays, 0 present not voting.
House Bill 819 passes and moves on to Finance, Ways and Means as amended. And if the attorneys would roll those two amendments into one amendment for the next committee. Thank you. All right. That brings us back to the start of the calendar. So that is item number 1, House Bill 2044 by Speaker Marsh. You have a motion and a second. Do we have an amendment? Okay. And I believe we have an amendment.
We do.
Drafting
Code 13463.
Drafting code 13463. I've got a motion and a second. If there's no objection, all those in favor say aye. Aye. Opposed? Ayes have it. We're on the bill as amended. You are recognized.
Thank you, Mr. Chairman and members. HB 2044 is a simple, necessary cleanup bill that brings last year's medical assistance legislation fully in line with the real clinical practices. First, it corrects an oversight by adding physician's assistants as authorized providers who may delegate tasks to certified medical assistants, something they already do in outpatient settings, but were accidentally left out of this bill last year. It also clarifies that clinics are responsible for training and verifying the competency of medical assistants, ensuring safety without adding new regulation burdens. It updates the inclusion and exclusion lists so clinics know exactly what medical assistants can and cannot do, adding clarity around vaccines, oral and topical meds, limited anesthesia, and making clear they cannot administer anesthesia, gases, or cosmetic agents such as Botox. Finally, the bill modernizes medication rules by allowing medical assistants to work with both single-dose and multi-dose medications so long as the provider orders a specific dose and performs any needed calculation. This replaces the outdated standard dose language, which doesn't reflect real-world prescribing for common weight-based medications like Tylenol. With that, I'll be glad to take any questions.
All righty. Do we have questions? Okay. Question has been called. Would the clerk please open the roll? Open the vote. All those in favor vote aye. All those opposed vote no. All right, clerk, please take the vote.
Mr. Chairman, you have 24 ayes, 0 nays.
All right, thank you. House Bill 2044 passes and moves on to government operations as amended. All right, that item number 2 had been rolled, so that brings us to item number 3, House Bill 1899 by Representative Slater. You are recognized. You have a motion and a second.
Thank you, Mr. Chairman. Residential homes for the aged support older adults by helping them secure permanent housing. This choice is often the best option for seniors to continue to live in their community and live close to their family members. Residential homes for the aged are licensed by the Tennessee Department of Disability and Aging or the Tennessee Health Facilities Commission based on the number of residents. This bill increases from 3 to 5 the maximum number of individuals that may live in a Tier 1 home for the aged, subject to licensure by the Department of Disability and Aging. It increases from 4 to 6 the minimum number of individuals that may live in a Tier 2 home for the aged, subject to licensure by the Health Facilities Commission. And I consulted with the Fire Marshal's office and also the Department of Disability and Aging, and this would not in any way lessen any of the safety and security of our residents. With that, I stand ready for questions.
All right, do we have any questions? Representative Capley, you're recognized. Okay, question has been called on House Bill 1899. Clerk, can you please open up the vote? All right, will you please take the vote?
Mr. Chairman, you have 22 ayes, 0 nays.
All right, House Bill 1899 passes and moves on to Finance, Ways and Means. Thank you. Okay. All right. That brings us to House Bill 2599 by Representative Shaw. You have a motion and a second. You are recognized.
Thank you, Mr. Chairman. This is the Alzheimer's Dementia Respite Care Pilot Program Bill. Chairman Williams started a while back, and we want to continue that program, if all possible, where we can give some of our Tennesseans who are caring for Alzheimer's patients a break now and then, give them a chance to get out, maybe get to the beauty shop, take care of some grocery items, other things. With that in mind, having understanding the legislation, I would stand for any questions that you might have.
Have any questions for the sponsor of the bill? All right, seeing none, we will be voting on House Bill 2599. Will the clerk please open the roll? All those in favor vote aye. All those opposed vote no. All right, will the clerk please take the roll? Take the vote. Oh,
Mr. Chairman, you have 22 ayes, 0 nays.
okay. House Bill 2599 passes and moves on to Finance, Ways and Means. All right, thank you. Who? Okay. Okay, that brings us to item number 6, House Bill 1470 by Representative Hicks. You are recognized.
Thank you, Mr. Chairman.
You have a motion and a second. Motion and a second.
Thank you, Mr. Chairman. House Bill 1470 prohibits a person who deploys, develops an artificial intelligence system from advertising or representing to the public that such system is or is able to act as a qualified mental health professional. The mental health professional services we are talking about here in this bill are the same ones that's listed and defined in Title 33. We all know that artificial intelligence is a powerful tool that has a lot of excellent uses in healthcare. We believe that if therapy is being provided, that there needs to be a human therapist engaged with the patient and not just a bot. So thank you, Mr. Chairman. I'll take any questions.
All right, thank you. We have Mr. Paul Herbert who would like to speak. Are they here? All right, without objection, we'll go out of session. If you can, we'll have you state your name and who you're with, and then you'll have 3 minutes.
Okay, my name is Paul Hebert.
Oh, if you can, pull the microphone.
There we go. My name is Paul Hebert, and I'm the founder of the AI Recovery Collective. Mr. Chairman and members of the committee, thank you for this time. I'm a Silicon Valley tech veteran with 30 years in the industry, and I'm also an AI harm survivor. I'm here in support of HB 1470. I want to tell you something that took me a long time to say out loud. I was psychologically harmed by an AI chatbot. Despite being an early adopter of the internet technology from the .com era, I'm not naive about artificial intelligence. I wrote software, I understand software architecture, but it still happened to me. If it can happen to a 30-year tech veteran, it will happen to anyone who turns to an AI system in a moment of genuine mental health crisis. And millions of people are doing exactly that. Right now, 13.1% of the American youth use AI chatbots specifically for mental health advice. 22% of adults age 18 to 21 report AI as their primary mental health resource. The average wait for a real behavioral health appointment is 48 days. That gap is being filled by software that has no license, no ethics boards, and literally zero accountability, and that actively presents itself as something it is not. A peer-reviewed study validated by 43 practicing therapists found that as users disclose escalating suicidal risk to AI chatbots, the AI becomes measurably less likely to engage. It abandons users at the exact moment of the greatest crisis. 43 clinicians reviewed the transcripts and called it what it is: minimalization and dismissal. HB 1470 does not ban artificial intelligence, nor does it restrict innovation. It requires one thing everybody can agree on: honesty. If a product is not licensed, the product is not a licensed mental health professional, it cannot claim to be, nor can it be marketed as one. That is a consumer protection principle Tennessee has always upheld, and there is no reason AI should be exempt from it. I respectfully urge this committee to pass HB 1470. The people who turn to these systems deserve to know what they're talking to. Thank you for your time.
All right. Thank you for that explanation. Thank you for coming up here and giving us your experience. And do we have any questions while we're out of session? All right. Seeing none, we will go back to session. Thank you.
Thank you.
Any further questions for the sponsor of the bill? Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. My concern on this legislation, though, currently I think there's a lot of school systems out there that these systems, kind of elevate that, the students will be talking to a chat bot, and the system will be able to figure out if they need to elevate them to talk to a human therapist, or, if they need to, it even knows whether it should call 911 or not. And fortunately or unfortunately, that's all a lot of these school systems can afford. And if we go forward with this legislation, currently with the mental health crisis that our youth have, it's something right now. But if we go forward this legislation, they'll have nothing. Is there going to be mistakes? Unfortunately, probably but there is also human error at times too. So that's my only concern is, are we tying the hands of our school systems that can barely afford systems that I'm referring to then the kids are going to have nothing. So I don't know which is better. Thanks.
You're recognized.
Thank you, Mr. Chairman. And, I think with the money that we have put out for mental health liaisons in our schools, and that's exactly what this bill is doing is it's allowing that person to use and deploy and to use AI. But by no means can they advertise that it has to be a human. And I think no matter what, we have to keep it that way. I don't think we can let happen what you referred to there. I don't think that's at all what we need in this state. So there is resources for mental health providers in our schools, and I think there's even more this year that we're trying to get out there as well. So I would hope and pray that in our schools and for our teenagers, just exactly what the gentleman talked about. I appreciate his enthusiasm and his work in this, because he's put out some great articles that I've read. He sent them to me, and it's really interesting conversations to have. It's something that we're going to have to continue to work on. So, but I thank you for the question, and I'll be happy to answer any more.
Any further questions for the sponsor of the bill? All right, seeing none, will the clerk please open the vote? All those in favor vote aye. All those opposed vote no. Okay. Will the clerk please take the vote?
Mr. Chairman, you have 20 ayes, 0 nays.
All right. House Bill 1470 passes and moves on to calendar and rules. All right, thank you. And I am going to put out my sincerest apologies to the members that we were not able to get to today. The first bill needed some significant debate, and we started a little bit behind, but my serious apologies to all that, anybody that came here. But all those bills that are left on this calendar will be placed on next week's calendar without objection. Seeing no further business before us, we are adjourned.